Hello, my name is Lauren Livengood, and I'm going to be presenting a case on depression. Our patient's name is Janelle. She's a 35-year-old woman with diagnosis of depression. She's been taking fluoxetine 40 milligrams daily for the past year and describes that she feels a little better because of the medication, but is not as happy as she should be. Janelle currently lives with her husband of 10 years and describes him as being supportive. She's stayed at home to raise their two children who are 5 and 8. Recently, friends and family members have been asking Janelle about whether she'll be returning to work now that their youngest child has entered kindergarten. She relates that the idea of returning to work has made her very anxious. Although no one is pressuring her to do so, the idea is so overwhelming that it's keeping her up at night. She sees a counselor every other week and states that it's a little helpful, but ultimately she would like to see if there's anything we can do about the medication. Subjective information about Janelle. She has a medical history of having an appendectomy at age 14. Otherwise, she's medically healthy. Mental health diagnosis of depression. She's a non-smoker, 1 to 2 drinks per month, no substance use history. Currently, she's taking the fluoxetine 40 milligrams, and she reports that she takes ibuprofen from time to time for headaches. No known drug allergies. In terms of family history, her mother and father are still married. Her mother has a history of anxiety and hypothyroidism. Father, depression, alcohol use, which Janelle has described as functional alcohol use, as he was able to work, although he wasn't present during a lot of her childhood. He also has a diagnosis of long QT syndrome. Sister has a diagnosis of anxiety and IBS. In looking at the family history, the depression is there as well as the anxiety, and given some of the recent circumstances where Janelle is continuing to sort of perseverate on things, we may be looking at anxiety for her as well. Objective findings. We're looking at vital signs here that we took. Those look fine. We're doing a quick review of systems, which were all within normal limits. And BMI is the one thing here that has decreased. Can be an indication of depression, so we'll want to make sure to ask Janelle if she has been trying to lose weight intentionally, or if it wasn't, maybe this is a sign that depression has worsened, maybe anxiety has increased. We'll do a depression screening test with her, as this is going to be our focus for this visit. The patient health questionnaire, the PHQ-9, is a standard form, although there are quite a few of them. They can be done with a practitioner, or the patient can do them before the meeting with the practitioner. Labs that are especially important for Janelle are going to be TSH, CMP, CBC, vitamin B12, a BUN and creatinine, and liver function. We're definitely going to check out the TSH. Mom had a history of hypothyroidism, so we're going to check that in her. We'll say that her labs came back fine. We're checking for other things such as anemia, electrolyte imbalances, anything that could be medical that is causing symptoms of depression, and ruling those out so that we know that we're treating the right thing here. Although most of the medications are excreted by the liver, there is some involvement with the kidneys, so having those tests done will be important as well. Depression and anxiety. Often people will have both of these diagnoses, and in the case of this patient, she has a family history of anxiety, so I think it's important to look at both of these. Depression, feelings of hopelessness, depressed mood, anhedonia, which is a loss of interest in doing things one normally likes to do. Weight could go up or down. Sleep could be too much or too little. Fatigue, loss in concentration. We're not worried about it in this patient, but eventually suicidal ideation or suicide attempts. These symptoms need to last for 2 or more weeks in order for a diagnosis to be made. The pathophysiology of depression is not fully understood, but we do know there's decreases in serotonin and other neurotransmitters that play a role. Risk factors include biochemistry, genetics, personality, and environment. And depression is definitely more prevalent in women. Anxiety. According to the APA, anticipation of future concerns, muscle tension, and avoidance behaviors are all symptoms that are seen in anxiety. A diagnosis is made when people are unable to function normally. They have ideas that feel out of proportion to the actual situation, or they're having worries that are not appropriate to their age. The neurotransmitters involved with anxiety, again, occur within the CNS, similar to depression, and involve a lot of the same actors, although this one involves GABA as well, so that's a difference there. Risk factors, again, biochemistry, genetics, the environment, and then past trauma for anxiety, which can bring up new anxieties for a person. A therapeutic plan for Janelle involves switching her from fluoxetine to sertraline. Looking into a behavioral approach, she does see a counselor, but we can discuss that, and complementary therapies that may help her as well. Switching medications for Janelle. We're going to be switching her fluoxetine to sertraline. Both of these are SSRIs, so why would we switch one to another? Let's look at how they work first. The mechanism of action, although not well understood, is that they increase serotonin levels by blocking reuptake within the synaptic cleft. The majority of excretion is through the liver, although there's some involvement with the kidney. And it's the pharmacokinetics that's important because they vary between SSRIs, which is most likely why some work particularly well for certain people while others don't. And oftentimes we figure this out through trial and error. Taking a look at fluoxetine, it treats many disorders. Major depressive disorder is one of them, along with PMDD. So this would be a good choice for women. One of its downsides is that it has a side effect or adverse reaction of creating prolonged QT interval. Given the fact that her father has this as part of his medical history, this would probably be a poor choice for Janelle, and it would be a good idea that we're switching her off of it. Some of the SSRIs like Celexa also are known for prolonging QT interval, and there are other medications that can do this, such as antibiotics, so it's important to keep that in mind. It's about $48 for a month supply of the fluoxetine, which isn't horrible. So let's look at sertraline though. It treats the same disorders, but it also treats anxiety, which would be great for this patient. For a 1 month supply is $30, so that's less, and we're sort of ahead in the game that way. And looking at half-life for both of these, this is going to be important when we're talking about switching the two medications. Half-life for sertraline is about a day, whereas the half-life for fluoxetine is 4 to 6 days. This is going to cause us to take some special consideration when we switch the two of them. Switching fluoxetine to sertraline. As mentioned in the previous slide, there are different half-lives involved, and we don't really want the two of them to overlap. Overlapping them can cause serotonin syndrome, SIADH, hyponatremia, CNS depression, psychomotor impairment, and so we really don't want these two together. Our patient, Janelle, is not actively suicidal. She's not at high risk here, and so I would be taking a conservative approach with her. In this case, a conservative approach would be to decrease the amount of fluoxetine that she's taking, and this is going to be done over the course of weeks. She's taking 40 milligrams right now, so one way to do this would be that she would take 40 milligrams one day, 20 milligrams the next day, and you would alternate this, eventually then decreasing it to 20 milligrams one day and alternating with days where she's not taking any of the medication because of the long half-life. We can do this. This would be over the course of weeks. Once this is completed with a conservative approach, you would have a washout period of time where a person is not on the medication for the course of 5 half-lives of the original medication she was taking. So this is a few weeks at least for the fluoxetine to be out of her system. at that point in time, you would start the sertraline to the recommended dosage, which in this case, you start on either 25 or 50 milligrams PO daily, and you can adjust it as indicated. Moderate approaches involve having a shorter washout period, direct switches as it appears, and a cross taper would be reducing the amount of one medication and then introducing the next medication at a lower dosage. The last two approaches are done mostly for more acute situations, wouldn't be done in general practice. When someone's suicidal and we're needing to keep a medication on board, obviously it comes with more risks, and so that would not be the approach I'd be taking. Sertraline, teaching and information. As far as antidepressants go, the SSRIs are one of the safest. They have low overdose potential, fewer side effects than many of the others. They do have black box warning, which is typical for antidepressants, meaning there's an increased risk of suicide within the first few weeks of giving it. So client and teaching would involve having the patient call if there was an increase or change in mood, letting her know that it's going to take about 4 weeks for this medication to really kick in and start working. It's a good medication choice for her as it treats the PMDD. There are women that take it during pregnancy, and sertraline has been shown to be one of the safest in nursing and lactation. So if she were to have another child, that would be good. Drug-drug and drug-food interactions. There are many, although these have fewer than some of the other antidepressants. They inhibit cytochrome P450, which is important consideration to keep in mind. Antiplatelet effects. She does take ibuprofen. It can increase bleeding, so we'll want to talk to her about that. Drinking alcohol should be pretty limited, as it also causes CNS depression. Looking at fluids and balance with hyponatremia. Decreases seizure threshold, serotonergic effects, and also letting her know that St. John's wort is another one that should not be taken with this. As often people know that this will help with depression, they may not think of it as having interactions with the medication, but it does. Common side effects are GI upset, especially when you're first starting to take this medication. Changes in energy, it can raise or lower them, and it's variable between person or person, and it can be a deciding factor of when you take it, whether it's morning or evening. And sexual dysfunction is one of the more common side effects, and you could have her report this to you if that's happening and something that is not working for her in terms of the medication. Follow-up and monitoring, we'll have checked the liver and kidney functions, and we'll want to do a mental health check-in with her within that first 4 weeks and continue to do that at least monthly until we decide exactly what the dosage will be with her medication. Looking at this patient in a behavioral approach, Janelle already sees a counselor, but she doesn't feel like it's working so well. There's quite a few different methods for behavioral therapy. There's CBT, which is cognitive behavioral therapy, among many others. Some counselors tend to use one approach, while other counselors use different approaches. Many of these can be practical solutions to sort of working through daily situations, and if one counselor and one method doesn't work, there's always sort of the option of trying another. Part of my role in this could be to refer Janelle to another counselor, as this may be helpful for her. Complementary practices and therapies are another great option for patients. Talking about diet, there's studies that have shown increases in sugar can actually lead to depression. Exercise is beneficial for lessening symptoms of depression and anxiety. Sleep, healthy sleep patterns anyway, can be helpful at moderating that. Meditation, breathing exercises, guided imagery, all of these great for anxiety, especially during more acute situations. Yoga, acupuncture, all of these have been shown to be beneficial. And the wonderful thing about all of these is that they are side effect free for the most part and don't have interactions with any medications. And so, kind of looking at all of these complementary practices, behavioral approaches, and the medications as well, we're looking at a real comprehensive approach to treating depression and anxiety, as some will work a little bit better for others. The medications themselves are definitely can help jumpstart folks into feeling well enough in order to be doing some of the other approaches that are helpful to them. And it's really sort of tailoring and looking at each individual as to what will work for them as a therapeutic approach. So I hope you enjoyed the presentation, and I appreciate your listening.